Assalamu alaikum. So continuing with our rheumatology topics, let us discuss a case. This was a female patient, a young female patient who presented with edema of feet. And when she presented to the hospital, the doctor who saw her thought that this was apparently from a recent flight, and she was advised to sleep with legs elevated, and the edema resolved. At 6 months after that, the patient again presented to the hospital, and she said that she had joint pains, and because this was winter, she also complained of having very cold hands and feet, and there was a low-grade fever. Her flu test was negative, and she was referred for X-ray of the painful joints, which were done, and she was scheduled for a follow-up. A month later, on follow-up, the X-rays showed no erosions or subluxations. X-rays were normal, and the patient reported that she was symptom-free now. And the patient was advised to make an appointment if the symptoms return. So no specific management or treatment was given to the patient as the patient was symptom-free. Around 7 months after that, she developed a rash on her cheeks and nose, and she was referred to a dermatologist who diagnosed her with rosacea and gave her topical medication for application. Around 4 or 5 months after that, the patient had severe abdominal pain and reported occasional fever, and she was referred to a gastroenterologist. The gastroenterologist said that the patient's symptoms had uh, resolved before the appointment and gave a possible diagnosis of an infection or an inflammatory bowel disease. In July of the same year, the patient presented with symptoms of Raynaud's phenomenon, and she was referred to a dermatologist. So it took her 2 years to get to a diagnosis of SLE. Unfortunately, this story is not unusual, and early diagnosis of rheumatological diseases is really difficult. We are today going to discuss a rheumatological disease, a connective tissue disease, which is systemic lupus erythematosus. So think of another case, a 35-year-old lady who presented with fever and joint pains for 1 month. There's also history of oral ulceration and rash on face for the last 6 months. The rash became more severe on exposure to sunlight. When we talk about systemic lupus erythematosus, think of this picture and remember that multiple systems are going to be involved. So the pulmonary systems may be involved, the cardiovascular system, including the heart, the endocardium, the myocardium, the pericardium, and the vessels may be involved. The gut may be involved. We know that because this is a rheumatological disease, muscles and joints are going to be involved. The mucosa and the skin can be involved. So when we say systemic, it means multi-systemic effects. And when we say lupus, lupus stands for wolf. So the skin wounds are like gnawed into the skin of the patient, gnawed like wolf bites. So systemic lupus erythematosus, a red rash, a red butterfly rash, which is typical, which is a diagnostic criteria of systemic lupus erythematosus. So the objectives of this lecture are that you are going to be able to define this disease. You would know which population and which age groups, thus the epidemiology of this disease, the pathogenesis, clinical features. You will be able to enumerate the diagnostic criteria, and you should be able to delineate a management plan for this patient. So SLE, when we say, tell us the definition, we want you to tell me these red words immediately. And remember the green words. So it is an inflammatory, multi-system, autoimmune rheumatic disease. So remember, inflammatory, multi-system, autoimmune rheumatic disease with arthralgia and rashes as the most common clinical disorder, and cerebral and renal disease as the most serious problems. As we have already said that multiple systems are going to be involved, so there will be a wide range of presentations, and this is a disease of remissions and relapses, and the patient may have symptoms and the patient may have disease-free periods during that time. Remember this, the kidneys and the brain. So remember this. This can affect um people all over the world. Females are 9 times more commonly affected as compared to males. Um, African people are 3 times more affected as compared to Caucasians, and it usually affects the age group of 20 to 40 years. Um, there is a genetic predisposition for people to have this disease. So a family history of SLE will make a person more prone to develop this disease. And then there are hormonal influences. So in pregnancy, in the disease may either flare or remit, or this also has got an association with the menstrual cycle. So hormonal influences, so oral contraceptive drugs may precipitate a relapse of the disease. Then there are environmental triggers. If the patient with SLE goes out into the sun and there's UV light exposure, she may develop a flare. There are some drugs which can lead to a flare of SLE or the development of SLE. So there is some drug-induced SLE. For example, there are some anti-tuberculous agents like isoniazid, and there are some antihypertensive agents which can lead to precipitation of systemic lupus erythematosus. And then there may be infective triggers like some viral infections. And basically, there's immune dysregulation caused by genetic, hormonal, and environmental factors. And this immune dysregulation leads to formation of immune complexes and the development of autoantibodies. This will lead to release of cytokines and activation of the T cells, which are going to affect multiple systems like the cardiovascular system, the neurological system, the pulmonary system, skin, and the kidneys, to name a few, and will lead to inflammation in these systems. So there is an innate susceptibility, which when combined with environmental stimuli, will lead to autoimmune proliferation, activation of the T cells, defective immune complex clearance, and lead to also autoantibody production, which can lead to multi-system inflammations. Most visceral lesions are mediated by deposition of immune complexes, which is type 3 hypersensitivity reaction. Autoantibodies against red cells, white cells, and platelets mediate their effects via type 2 hypersensitivity, with leading to lysis of all these cells. So there would be hemolysis leading to anemia, the lysis of white blood cells leading to leukopenia, and of platelets leading to thrombocytopenia. We will come back to these features when we discuss the clinical features. In tissues, nuclei of damaged cells react with anti-nucleic acid antibodies, lose their chromatin pattern, and become homogeneous to produce specific antibodies, which can be seen in histopathology. When we talk about the clinical features, we said that this is a multisystemic disease with skin manifestations and renal manifestations, neuropsychiatric manifestations, musculoarthritic, cardiac, respiratory, hematological, gastrointestinal, and involvement of the eyes. But always remember, the patient may come to you with constitutional symptoms, which are non-specific but are very common. The patient may present with fever. So remember that every fever is not because of an infection. The patient may also present with weight loss or fatigue because of the inflammations set up inside the body. Then there are skin manifestation. The acute manifestation may be a malar or a butterfly rash, generalized erythema, or a bullous leukoerythematosus. Subacute cutaneous lupus erythematosus and chronic lupus can also occur with which can present as localized discoid. So you can see that this gentleman has got a butterfly rash and the lady has got a generalized photosensitive erythema, which are typical of acute lupus erythematosus. So not only the skin, but the mucous membrane can be affected with involvement of the oral mucosa, visible as oral ulcers in these pictures. And other non-specific lesions can be urticaria, vasculitis, livedo reticularis, alopecia, photosensitivity, purpura, and Raynaud's phenomenon. So when vasculitis occurs, it can lead to either palpebral purpura or, as you can see in this picture, fingertip ulcers, because vasculitis leads to destruction and necrosis of the tissue distal to the area which the specific blood vessel is supplying. Because as you know, with vasculitis, inflammation of the blood vessel will occur, and this will affect the blood supply to the specific area. This is livedo reticularis in the other picture that you can see. So livid means purple. So there's a purplish net. Reticularis means net. Purplish net seen on the lower limbs, usually thighs. And this is because of vasculitis of the dermal vessels, dermal arterioles. And this is a vasculitic phenomenon. Alopecia can also occur, and you can see that there is Raynaud's phenomenon in this picture. When we talk about muscles and bones, arthritis can occur, but arthritis is usually it's arthralgia. It's not a very uh, fulminant or prominent arthritis that occurs with SLE. Usually it's non-erosive and rarely deforming. There is mild inflammation. That is, it's not a very strong arthritis. Usually we call it an arthralgia. And there can be myopathy, there can be myositis or myopathy secondary to the drugs which the patient is taking for treatment. In renal disease, which we call lupus nephritis, which is a very important manifestation of SLE, there can be proteinuria, there may be urinary gas, hematuria, pyuria, and renal vein thrombosis. This is one of the most serious complications that can occur in SLE and requires aggressive management of the patient. And this occurs in around 30 to 65% of the patients. Then serositis can occur with pleuritis, with pleurisy or pleural effusion occurring as a result of pleuritis, pericarditis, and peritonitis. In cardiac manifestation, we have already talked about pericarditis leading to, as you can see in this picture, pericardial effusion and a large globular heart. There may also be myocarditis leading to cardiac failure or endocarditis, which is an aseptic endocarditis. Usually endocarditis occur with infection, but this is an aseptic endocarditis, and this is called a Liebman sac endocarditis. This is also, please remember, this can be an exam question. And if there's vasculitis of the coronaries, there will be coronary heart disease in the patients. In pulmonary manifestations, we've already talked about pleuritis. Then there can be pneumonitis with pulmonary hemorrhage, pulmonary hypertension, and pulmonary embolism. In hematological manifestations, anemia, leukopenia, lymphopenia, or thrombocytopenia can occur because of lysis of the involved blood cells. In neuropsychiatric SLE, they can be, as you can see in the list, involvement of the central nervous system and the peripheral nervous system. these manifestations are enumerated in this list. What we need to know are the diagnostic criteria. And the diagnostic criteria are these 11 diagnostic criterias, which include malar rash, discoid lupus, photosensitivity, oral or nasal ulcers, non-erosive arthritis, serositis, nephritis, neurological manifestations. And this means neuropsychiatric manifestations, hematological manifestations, immunological manifestations, and presence of antinuclear antibodies. Presence of any 4 of these manifestations present over a period of 6 months will lead to a diagnosis of SLE. So एक एक्रोनिम बना हुआ है सोप ब्रेन MD, याद रखने के लिए सोप का S वो सीरोसाइटिस, ओरल अल्सर्स, आर्थराइटिस, फोटोसेंसिटिविटी. ब्रेन में B is for blood, renal, ANA, immunologic, neurologic, malar rash, and discoid rash. So SOAP brain MD is the mnemonic for the diagnostic criteria of SLE. When you think about what investigations will you order for the patient in which you suspect SLE, you are not only going to confirm the presence of SLE, but you are also going to see which systems are affected and whether any complications have occurred or not. So you are going to do, हमने जो list की थी in our initial lecture, how do we proceed about investigating a patient with rheumatological disease? तो उसमें हमने कहा था कि आपने हेमाटोलॉजिकल टेस्ट कराने हैं, बायोकेमिस्ट्री करानी है, इम्यूनोलॉजी करानी है, अगर ज़रूरत पड़े तो जॉइंट फ्लूइड एस्पिरेट कराना है, और फिर इमेजिंग करानी है. So depending on the symptoms of the patient or depending on your clinical diagnosis, you are going to offer the patient a list of investigations. If you do the hematological investigations in which you're going to look at the CBC and you're going to go for the inflammatory markers, the patient, as we have said, that the patient can have anemia, leukopenia, lymphopenia, or thrombocytopenia. The ESR may be increased. The CRP is usually normal, but may be raised in arthritis, pleuritis, or coexisting infection. If the kidneys are involved, urea and creatinine are going to be deranged, and urine analysis should always be done, even if the patient does not have any renal manifestations, any symptoms or signs of renal involvement. Always do a urine analysis to check for protein, RBCs, WBCs, or casts, any of the casts. In spot urine test for creatinine and protein concentration. So albumin creatinine ratio कराते हैं उसमें, and 24-hour urine test for creatinine clearance and protein and serum proteins if required. Then autoantibodies and serum complement levels should be done. ANA, anti-double stranded DNA, which is specific for SLE, anti-SM, which is also very specific for SLE, antiphospholipid antibodies if you are suspecting antiphospholipid syndrome. Then complement will be low in patients who have got active SLE, and anti-nucleosome antibodies and TC1Q antibodies in specific cases. Diagnostic imaging can be required if there's neuropsychiatric symptoms. We need to go for MRI brain. CT scan sometimes can be required. For example, if we are thinking that there is pneumonitis or interstitial lung disease, we may need to go for an HRCT and histology with classical, histological, and immunofluorescent abnormalities on skin and renal biopsy. Whenever there is renal involvement of a patient who has got SLE, we need to have a renal biopsy in order to stage the disease so that a specific management can be offered to the patient. How are you going to manage a patient with SLE? You're going to treat active lupus and prevent damage from occurring, and the damage can be from the disease the anti-inflammatory agents that you give or the immunosuppressive agents that you give. And you're going to prevent the relapses from occurring. And our approach is going to be that use the drug with the least side effects, use the lowest dose of that drug to control the disease and to prevent long-term damage. In mild diseases, avoid steroids. In severe diseases, especially in renal and neuropsychiatric involvement, aggressive treatment is required. So as you remember, whenever we have got a patient with a rheumatological disease, we are going to think about the non-pharmacological management and the pharmacological management. The non-pharmacological management in this case would be avoidance of going into the sun without application of a good sunblock. So a sunblock with SPF 60 should be used in these patients. Avoidance of people who have got infection so that flare is not, a relapse is not precipitated. Then you're going to use anti-inflammatory agent and then disease-modifying immunosuppressive agents. So anti-inflammatory agents are NSAIDs and corticosteroids. So as in the previous slides, we said that in mild diseases, we usually don't use corticosteroids. In mild diseases where there is skin or musculoskeletal involvement only, hydroxychloroquine can be adequate. But you can also use azathioprine, methotrexate, in people who have got multi-system effects. Cyclophosphamide and cyclosporin mycophenolate mofetil usually is used when there is severe disease or whenever there is involvement of the renal or the neuropsychiatric manifestations of SLE. Sometimes IV immunoglobulin and thalidomide have been used in certain manifestations of SLE. This is another case, a 45-year-old lady who presented with weakness of the right side, so a neurological involvement. She's not hypertensive or diabetic. She's divorced because she was unable to bear a child in 8 years of marriage, and there's past history of 3 abortions. What would you think of in this case? What would be the diagnosis in this case? The diagnosis would most likely be, and is going to be anti-phospholipid antibody syndrome with recurrent vascular thrombosis, which may be venous or arterial, recurrent spontaneous abortions, and recurrent cerebrovascular events and thrombocytopenia. So this is an acquired immune-mediated hypercoagulable state, which is sometimes associated with SLE. So you can go through the definition in this slide. And this is because of development of antibodies against the phospholipid membranes, especially beta-2 GPI, which lead to thrombosis, platelet consumption, and thrombocytopenia. So they are antiphospholipid antibodies which cause thrombosis in arteries and veins. These thrombi may break free and embolize, leading to manifestations of embolisms. And arterial thrombosis, which are more common in males, can cause heart attack, stroke, or limb ischemia. And there is fetal loss. There are a history of abortions. The investigations are anti-cardiolipin test, anti-lipase anticoagulant, and anti-beta-2 glycoprotein 1 antibodies. The clinical manifestations are enumerated in this slide, and the management involves long-term anticoagulation with warfarin. Pregnant patients are given aspirin and heparin, and prophylactic aspirin or clopidogrel. So thank you. We'll be discussing the questions during the lecture if you have any questions related to this topic.